Support for Digging Deeper comes from
the Penn State Alumni Association, keeping alumni connected to the university and to each other. Membership information at alumni.psu.edu/belong.
and from viewers like you. Thank you.
Hi, I'm Andrew Destin. Telemedicine has been a growing trend in healthcare for years. It can increase access to healthcare in smaller communities and make routine appointments more convenient. Just how popular has telemedicine become in recent years, and how might it continue to grow? And what role has the COVID-19 pandemic played in its growth over the last 2 years? On this episode of Digging Deeper, Penn State President Eric Barron talks to Christopher Lecoux, Vice President of Virtual Health for Penn State Health, and Dr. Mark Iantoska, Professor of Neurosurgery.
Thank you so much, both of you, for joining me today. You know, it seems like such a fascinating topic, but maybe we should begin, because I imagine people have different perspectives. What exactly is telemedicine?
So telemedicine is the delivery of medical services by simultaneous audio and video means, right? Obviously, we've had the technology to do that for quite some time, but prior to the COVID pandemic, there's been limited use. The use of it has been limited to certain specialties, certain specialty areas where there are limited specialists or shortages to provide those services in clinical situations that kind of lended themselves to a video interface. There were a lot of regulatory limitations in place prior to COVID, which were removed in March of 2020, that allowed our telehealth implementation to really explosively grow at that time.
So limited use just because of regulations, but the definition is pretty broad, it sounds like. So it could be an appointment with a doctor. What about something like emergency personnel at a crash site where they're wearing a helmet and they're communicating with a doctor, and there's video on the helmet? Is that telemedicine too?
I would certainly classify that as telemedicine. I'm sure it's something that the military has been providing for quite some time. Christopher, do you have anything to add with that at all, or?
Yeah, no, I think that fits the definition, certainly. I think the definition is pretty broad, and that the two-way audio video communicating provider to provider, nurse or medic to emergency medical physician or neurosurgeon, certainly fits that definition. So
growing before COVID, but at a relatively slow pace for things that are specific. Granted. So now what happens with COVID? So the gloves come off on a particular date, but
pretty much. The things that sort of limited telehealth implementation prior to COVID were one, lack of clarity on how or whether services could or would be paid for. There was a number of government regulations on Medicare payments that included that patients or doctors had to be in a specific underserved area to be able to be authorized to provide telehealth. There also was a requirement that the provider would have had to have a face-to-face visit with the patient in a certain period of time prior to having a telehealth visit. There were some components of the HIPAA ruling that prevented certain forms of telehealth visits, such as audio only visits, which were limited, and also interstate regulations, all sort of contributed to limiting the amount that providers and institutions could utilize telehealth. So places like the VA is probably the best example of an institution that was able to use it a lot more than some of the others. And we saw for many years studying the results that they had utilizing telehealth that a lot of the costs could potentially be contained and that the quality of care was very good and the patient satisfaction with it was excellent, but just could not really implement it. So certain specialty areas, so teleradiology was one where, remote institutions might not have access to a specialty radiologist. They could utilize telehealth services for that, or tele-ICU services. And then certain specialized clinics, for instance, we have a ALS clinic that where the patients have very extreme medical needs and it's very difficult to transport them. So they had government grants to support the use of telehealth because it would not be paid for by insurance. So we were able to develop that kind of program. But after mid-March 2020, basically all of those restrictions were removed with the emergency authorization. So the need to be in a remote area or to have seen the patient previously was removed by the federal government under the public health emergency. And that continues now. Most recently, it's been increased to mid-January, the public health emergency. And now we sort of get into this area where there are confusing, overlapping government and state regulations that come into play. So, for instance, Pennsylvania has extended their public health emergency to the end of March. So telehealth will be able to continue as it currently is in Pennsylvania till the end of March. And we suspect the federal government will lengthen their public health emergency when we get to January as well.
Interesting. Always the case where we have conflicting rules. So Chris, you have a title that suggests that Penn State Health is moving in this direction in a big way. Was that planning ahead, or did you sort of come alive in your position with these new rules and regulations?
Yeah, so prior to the March high water mark that Dr. Iantosca referred to, I served as an administrator at the Academic Medical Center, Milton Associate Medical Center. When the pandemic hit, the decision was made that someone needed to be in a role, looking, downrange beyond the curve in the road that we were dealing with. And so I joined the health system at that point in July of 2020 to take on virtual health, and been working in this capacity full time since then. Dr. Iantosca, prior to the pandemic, we had about 150 providers that were participating in telemedicine and utilizing some of our technology platforms. By about April 1st of the pandemic, we had around 2,200 providers, utilizing telemedicine as the stay-at-home orders really kicked in, and we were, closed in clinic spaces. So it was quite a time period then.
How do we see this? Are we learning a lot on what really works and what works well? I mean, I had a visit with a cardiologist and it was remote. And I must admit, the notion of not going to a doctor's office or to a hospital for which there was COVID infections, it made me feel good to touch base with the doctor and talk through some things without what I would say was a little bit of added risk. So I see the value in that particular case, but what do you want to see post the January or March or however these deadlines go? Did we just revolutionize medicine coming out of COVID? Or are we going to go back to a whole bunch of restrictions on this? Or are there places where it's clear this works really well?
I think the places that we've learned where it works really, really well is in areas like mental health, counseling, behavioral health types of things. Initial visits, I think, is a space that it works really well in. Some urgent care for certain ailments and conditions. Post-op care, we've seen a lot of success in post-op follow-up visits, and chronic conditions and chronic care. I think as a health system, what we're very interested in investing in is, time between visits and how we can stay connected with our patients, and, collect useful data that our providers can utilize. So remote patient monitoring is an area that we plan to invest heavily in over the coming months and years to manage chronic conditions. That's one area that we're focusing on. I think we're now, since the pandemic health emergency is sort of quieted to some degree, and we'll see these changes, are thinking about other types of hybrid products and services. Depending on which research you read or article, there are some that say about 80% of conditions can be treated through a telemedicine connection. Obviously, not everything. You can't do surgery that way. If there's a need to lay hands on with a stethoscope, those kinds of things. Although there are some technologies now that are out there that are equally as good. 12 lead EKGs with 4 fingers on a little pad for $69. So
and send it to your doctor.
Yeah, the technology is getting really good. So you can start to see a future where these types of things can help physicians diagnose and treat
and help patients. I imagine that there's also the fact that you've got patients that their mobility makes it hard for them to go to the doctor's office or to the hospital. So Mark, I have to say that I look at your title and neurosurgery and I say, okay, that's a surprising place to have a pioneer in telemedicine. So could you give us examples of how this works for you?
Sure. Well, one of the things Chris was mentioning is that there are patients that have to have a lot of visits, and there are some of those patients in neurosurgery too. So, for instance, my specialty is pediatric neurosurgery. We have a lot of patients that have implanted devices, whether they're medicine delivery pumps or stimulation devices that are programmed or are being followed long-term, say for a cancer condition, and have to have radiology studies periodically. Those types of visits in sort of routine post-operative visits or routine visits after an emergency room visit really are very amenable even within neurosurgery for telehealth. And we're learning all the time. There's been about 10 different papers within neurosurgery, and I'm sure the other specialties as well, about how to perform these exams remotely and how to sort of modify what you're doing so you can get a good exam remotely. There's an absolute explosion in the patient monitoring devices, not just typical blood pressure, temperature. There are Bluetooth stethoscopes and Bluetooth EKG machines that can be utilized for this. Our own researchers have developed gait analysis tools where you can attach a sensor to the patient's shoe and determine their stride length, and it will give you a pretty good analysis about whether that patient perhaps requires assistive devices like a walker or a cane, or what the risk of falls might be, and even doing a complicated pulmonary function testing for our ALS population. They have remote sensors where they can breathe into, and it will sort of let us know when someone's starting to get weaker and they might need to come in to see the physician. So I think that sort of marriage of devices and remote patient monitoring with the in-person visits to sort of let us know when an in-person visit is necessary, and to be able to predict when that's going to be in a more accurate way than just saying we need to bring this patient in every 3 months or every 6 months is going to be a big area of growth for telehealth for us going forward.
It's just as a brave new world. So, with a lot of brave new worlds, you have patients that love it and patients that don't. What is the patient reaction so far?
So we certainly see, have patients that we call and offer a telehealth visit and they don't want to do it. But, I've been actually surprised, in every institution, including our own, who has separately looked at their patient satisfaction for in-person and telehealth visits, has found that the telehealth visits compare favorably. And by that, I mean they're either equal or exceed the patient satisfaction in some cases for the in-person visit. So for the right patient that is willing and they're the right clinical situation, I think the satisfaction is very high, and the patients seem to really want it. Most of the time when I have telehealth visits for my chronic care patients, they indicate that they would like to do the next follow-up by telehealth if it's still available, and a lot of my colleagues see the same.
So Chris, is Penn State Health monitoring this so that you really have an ability to provide people with data on satisfaction?
Yes, so we routinely survey our patients, both for in person as well as virtual visits. We have functionality for some of our apps, our Penn State Health on Demand app, where we can actually collect real-time feedback on the provider, as well as the quality of the technology that they used for a 10 or 15-minute encounter, and we routinely share that throughout our medical groups and down to the provider level, actually, so they know where they stand at any given time.
A good patient reaction. How about physician satisfaction? Does the physician say, man, I just didn't give that my all because I couldn't do this and this? Or are physicians signaling that they see this as a very valuable way to be efficient and more helpful, especially as Mark was saying, with visits that are repetitive, for which you can save people that back and forth? Do we survey physicians as well?
So I don't know if it's as formal, right, Dr. Iantosca, but we definitely survey the physicians.
Yeah, not at this point, although, we can utilize, we can look at the utilization rates for different physicians and different services and kind of infer, how productive it is for them. I think, from the physician's perspective, obviously their main concern is that they're able to adequately evaluate the patient and provide quality, safe care. And so, the providers make the decision about which patients are appropriate for telehealth visits or not. And that is, that has to be done up front. And we're pretty good at doing that. I think the main concern where the providers differ a little bit is how efficient that is for them. If you have a mixture of in-person and telehealth visits, or if you're able to have enough telehealth visits that you can do dedicated, clinic slots and templates for that. And they definitely like having the increased access for their patients. It helps us shorten the wait time, and not just with patients. Like we will use it a lot we can set up telehealth conferences to talk to other physicians and train other physicians, or do a quick consult with another physician as well. And all of that is, in my mind, telehealth as well, right?
One of the things that I've been really interested in as well is the degree to which medical schools are sort of enabling doctors to be more personable, or have listening skills, or have a different sort of understanding, because patients seem to want, this is a very personal experience for an individual, obviously. So is there already the sense of a curriculum emerging or best practice emerging on how it is that you can be personal, but yet be in a Zoom call?
We certainly have those types of courses and teaching materials available for providers through our patient satisfaction programs. And the telehealth patients use those programs as well. So the providers monthly get information on their patient satisfaction scores, and they also get separate telehealth and in-person visit scores periodically, so they can tell that. There's a whole body of research and a number of papers that have emerged where, what's the best way to do a telehealth visit? How's the best way to instruct the patient to be, in a proper area of lighting, what to tell them to expect, those sorts of things. And I think we're really learning some new tricks about how to interact with the patient remotely to mimic the way that we do it in person. So yes, to answer your question, I think there will be a need for this type of training in the medical school curriculum going forward, because it is a different way of practicing. Our focus on the in-person physical exam has been there for hundreds of years, and this is a little bit different way of doing things. And I think the new generation picks this up really quickly.
I bet they do. I bet they do. So if you think about it sort of the ease and some of the other very positive attributes about this, maybe shortening the time to that appointment because you can have a quick check-in or something like that to understand it. One of the things that we had to deal with when Penn State went remote with our students is to recognize the vast difference in accessibility to broadband, to computers that allow. So are we creating, is this another factor in what is a digital divide that is going to have an impact on delivery of all sorts of things, but in this case, healthcare, because we might expect the rural patient to have different issues than the urban patient? Are you seeing that in Penn State Health's switch here to be able to do more things virtually? Did we run into a lot of technology problems or technology absence problems?
I think in the beginning we did, Dr. Barron. We saw gaps. We've overcome some of those, but I think longer term as we extend our reach beyond, say, just our 10 counties into other population centers, there are certainly challenges that we'll need to overcome, whether it's broadband, access to smart devices, Wi-Fi in some of our more urban areas. Those kinds of things I think are all yet to be worked on.
So I guess I was a little limited there. I was just thinking internet connection, but of course, if you don't have a lot of resources, you don't have the two-finger EKG either, right. Something that you have in your homes. Is that something that's likely to be prescribed and covered by health insurance at some point? How do you see this evolving?
Yeah, I mean, the funding for that, some will come through health insurance, traditional health insurance. If there's a medical necessity, and Dr. Iantosca needs remote patient monitoring and that patient doesn't have broadband or Wi-Fi or a smart device, the health system finding ways to deliver those services that are much needed. We've had to be creative in some ways with that, and there are some technologies out there that we can utilize to capture that data.
Yeah, when for the students we went remote, we discovered we were sending hotspots to some students, for example, just to be able to have access. So Mark, you have personal experience with this. Did you run into a lot of technology issues?
Not a lot. There were the inevitable technological issues, and all of the services that provide these telehealth backbones that we utilize were overwhelmed at first, but as you can imagine by the volume, we were doing 8 to 12 telehealth visits a day on average, and we went to some cases over 1,000 a day. So there was definitely some of that across the country at first, but that they adapted pretty quickly to that. But it's a very good discussion. I mean, you raise here, Dr. Barron, because there's this paradox that some of the patients that can benefit the most from telehealth, they're in a rural location or they have difficulty with transportation, are also the patients that might have more limited access to it. And I think, infrastructure bills, both at the federal and state level, have been introduced and in some cases passed to help spread the availability of broadband. And, there have been a number of pilots that healthcare systems have done where they actually provide the devices to the patients, or insurance companies provide the devices to the patients. And a lot of times that ends up being more cost effective than having them go back and forth to the visits.
I believe it. Yeah. So Chris, is Penn State Health developing a strategy where we'll lobby for permanent changes in the rules, not just emergency authorization, or are we seeing that future?
Yeah, I mean, we work closely with our governmental relations and payer contracting teams. Right now, there is a Senate bill that has passed, moving on to the House. Not sure it'll get done before the end of the year, but I think we're hopeful that we'll see next year not only a definition of, what it is in the state of Pennsylvania, but also, what parity would look like for telemedicine.
So sadly, we have very short time left in this program. It went so fast. How about a 10-second answer? Where will we be in 10 years?
Yeah, I mean, I think in 10 years, we see our utilization of tele in general, growing probably to around 35-40% of our total visits.
Wow.
And I think that the need is going to be there because, the number of patients that'll require care and the number of providers that we have will be inadequate. So I think this is definitely a way forward.
Well, this, you concur with that, Mark? I know we have.
I absolutely, and I think the public demand for it will increase as they become more familiar with it. Everybody has a cell phone now. As the public becomes more used to that technology, I think the only way that will go is to expand significantly. So,
well, I really appreciate the conversation, fascinating, and thank you so much for joining me today.
Thanks for having us.
Thank you, Dr. Barron.
Support for Digging Deeper comes from
the Penn State Alumni Association, keeping alumni connected to the university and to each other. Membership information at alumni.psu.edu/belong.
and from viewers like you. Thank you.